Γεια σας κυρίες και κύριοι. Συνεχίζουμε με την επόμενη Στρογγυλή Τράπεζα που αφορά ουσιαστικά κάποιες σύγχρονες προκλήσεις στην αντιμετώπιση του καρκίνου του μαστού. Αυτό ουσιαστικά που θα διαπραγματευτούμε σε αυτήν την τράπεζα είναι η χειρουργική με διατήρηση του μαστού, τόσο στις ακραίες περιπτώσεις αντιμετώπισης μεγάλων όγκων, όσο και στην ογκολογική ασφάλεια. Έχουμε δύο εξαιρετικούς ομιλητές που θα τους προλογίσουμε σε λίγο και τρεις εξαιρετικούς σχολιαστές, τον κύριο Μεταξά, την κυρία Σταφυλάκη και τον κύριο Καριδάκη. Δεν θα χαλάσουμε άλλο χρόνο, θα πούμε πρώτα τις δύο ομιλίες, θα ακολουθήσουν σύντομοι σχολιασμοί και μετά θα έχουμε χρόνο για συζήτηση και ερωτήσεις. Ναι, η συζήτηση θα είναι στα αγγλικά, οι ομιλίες θα είναι στα αγγλικά, το ζήτησαν και οι δύο ομιλητές, αλλά επειδή υπάρχουν και στο ακροατήριο ξένοι ακροατές, ζήτησαν και αυτοί να είναι στα αγγλικά για να μπορέσουν να συμμετέχουν στη συζήτηση.
So, I'm very glad that we have two speakers, Greek speakers that work abroad. Their topic is for breast-conserving surgery, and the two topics are going in the same direction, if we can avoid mastectomies, and if it's safe, or if it's safer to do breast-conserving surgery. The second speech from Mr. Zachariadakis is a little bit provocative, saying that it is better to do a lumpectomy than a mastectomy. So I'm going quickly to the first speaker, who is Andreas Karakatsanis. Andreas Karakatsanis is an associate professor in Uppsala, and he's a senior consultant and chief of breast surgery at the same hospital.
Thank you very much for your kind words. Thank you to the organizing committee for the honor of inviting me here. It's always a pleasure to come home. So we will be discussing breast-conserving surgery in the case of large tumors, and we will go through some definitions. These are my disclosures. The main disclosure about what I'm going to speak is that I'm going to speak about what is experienced as controversy routinely. And my other disclosure is that I come from a department that is currently doing 97% breast conservation for tumors up to 3 centimeters and 90% breast conservation for all tumors. And this at no cost of re-excision for margins or conventional mastectomy. And whilst we started doing that, we kind of felt that we became better in offering direct reconstruction in the mastectomy cases as well. So the key points of my talk is that breast conservation should be pursued on the grounds of equivalent, at least as good oncologic outcomes, but Kostas is going to lead us through the data. But at the same time, large means nothing without putting that into context. Successful breast conservation should be defined beyond the necessity of negative margins. Current cutoffs for what we decide to define as oncoplastic techniques need to be redefined because there is not robust evidence to support this classification. Standardized shared decision-making is a must, and it needs to be well defined. And thinking oncoplastic when you meet and assess an individual patient should be thinking about the standard of specific oncoplastic techniques. So thinking outside of the box is something imperative. And there is now some evidence for tailored approaches in selected patients, and we will shortly go through that. So what is a large lesion? By definition, we have the T stage from the TNM staging, but what is very standard for a clinical oncologist is not the same thing for us, because a 25 millimeter tumor can sit here or there, or here and there, or here and there at last. And you all know that we are talking about significantly different scenarios in how to choose the optimal surgery for these types of patients. And I feel that we need to rename the large lesion to what we call the large resection ratio, defined as the volume need to be resected divided by the breast volume. And the volume that needs to be resected is what we call the target area, what the radiation oncologist calls the target area, which is what we conventionally have been taught. You need to remove the tumor area with a macroscopic margin of 1 centimeter. And that is debatable, but this is due to convention. And this has been coined as the optimal resection volume, and there are different formulae to calculate that, with the ellipsoid formula being the most credible. And then the breast volume that can easily be obtained by different types of methods, ranging from the simple mammograms with different formula that have got a correlation index that is higher than 91% in all cases, the MRI for those that feel the need to be more sophisticated, it has not shown statistically significant accuracy compared to the others, and the clinical assessments, out of which the Longo formula is the one most well validated and unifying, which means that the deviations are not that significant depending on breast size. So, but is this enough? So is just a large resection ratio the absolute surrogate of who needs what and if a breast can be preserved? Traditionally, we learn from Krishna Kloff that up to 20% you can go with an oncoplastic level 1 technique, and from 20 to 50% you could go for that. But the problem with these classifications that have served very, very well the last 10 years in classifying different techniques is that they stem from studies that did not perform volumetry. So the assessment is a little bit arbitrary. There is no volumetric data on the cohort studies that Krishna Kloff and his team made these cutoffs. And so we don't know if they are correct, and we do not know if they are enough. At the same time, we know that the optimal operation is a combination of oncological safety in terms of safety margins, function, meaning symmetry and minimal morbidity following surgery, cosmesis per patient expectations, and of course, to be able to stratify out of all the things that we have in the arsenal, what is the simplest of all alternatives to begin with. Just touching on that, primary systemic therapy can increase breast-conserving surgery, and this has been shown in a meta-analysis of randomized control trials, but this is an effect that has been underutilized. So you see that from this meta-analysis, approximately 70% of BCT candidates with at least 50% of reduction at tumor size, which is what you know preoperatively, still got a mastectomy. And when we look at the pathologic complete response, approximately 60% of these patients, they got the mastectomy. They had path CR and they still got a mastectomy. And this is a knowledge gap that we need to work on very, very consistently, given the fact that pooled survival results nowadays have suggested that there is not any role for a mastectomy with superior outcomes with regards not only to overall survival, but also to locoregional control. And since that was interesting and cool with oncoplastic surgery, there were many fathers. So this is one algorithm, and this is one algorithm, and this is one more algorithm which I feel is more sensible because it takes all these things that we spoke about into consideration. And then there is one more algorithm, and interestingly, the title of this article is Keeping It Simple, but they suggest, for example, that you should do breast conservation and put an implant inside at the same time, which doesn't sound what you would instinctively think about. Unfortunately, none of these have been validated. So this is a proposal out of somebody's common sense. So when these people convened to discuss on a consensus, the only consensus they could land is that every oncoplastic procedure should be tailored to the individual patient. So this goes down the drain, more or less. And this has resulted in the fact that there is the absence of a feasible standardization system that will be uniform and there will be consensus around it. And why is that? Because this is what we have been taught. You start from the bread and butter wide local excision, the lumpectomy, moving on to level 1 techniques, level 2 techniques, and then to the mastectomy. But in reality, the choice of technique is so multi-parametric that it constitutes a continuum. So vertical decision trees cannot actually help you understand how to treat each and every patient in clinical practice. And we say that there are a variety of factors that are filtered through shared decision making, but this is rather too generic because the reality looks a little bit like that. And if I had a larger slide, it would have more branching, of course. So the nuances are endless and we need to find a way to think about it. So to treat equally means that we need to look upon these factors on an individual patient level. And instead of going to what we were used to, I think that it would be beneficial to break down everything in a manner that can be treated into data, because this will ensure that if we land somewhere well, we will be able to reproduce these results. So how do we define technique? This is something that we have started from 2019 in Uppsala with the OncoPro Value trial, which is an umbrella project that is looking into different aspects of how to do things. At first, we define a resection ratio. We know that the aesthetic outcomes, this is something that we have known from the Nottingham team already from 2003. If you have a more of a 10 cutoff, you will have inferior aesthetic outcomes, and this varies by quadrant. So you know that the medial breast tolerates much smaller resections than the lateral breast, for example. So a standardized assessment is beneficial, and when we did a study from Uppsala, we saw that if you matched patient-reported outcomes at the same level, postoperatively, the cutoff was about 7%. So that means that if you want to tailor surgery in a manner that is oncologically safe, but per patient wishes with adequate function and symmetry, and to tick all the boxes, your cutoff, in order to resort to something a little bit more advanced, is lower than what we have traditionally been taught to by the 20% rule. A practical approach, what I try to do. The preoperative planning has to be performed in a manner that serves the intention. So you need to have the resection ratio, you need to know where it sits in the breast, you need to know how to localize it. I personally use a combination of SPIO, which is MAC trace, and paramagnetic markers, the MAGSIT, but anything goes, so you just pick your favorite gadget. I often resort to intraoperative ultrasound in case of uncertainty, and I use intraoperative specimen radiography. And when it comes to transection, we infiltrate the area with local anesthetic and adrenaline, and the transection is performed with scalpel. This has made my pathologist love me a little bit more, because you do not land in the inconvenient situation where they say, oh, we have diathermy artifacts, we cannot assess the margins. And this is particularly helpful in the setting of DCIS, where 2 mm margins are usually wished upon. And if separate excisions are planned, because now there is some data on that, you should, among other things, think practically and assess the viability of the parenchyma in between. So sometimes it is not worth doing 2 smaller excisions if the parenchyma in between does not serve a purpose in the reconstruction or lacks adequate circulation. With regards to this, the data following neoadjuvant chemotherapy from a pooled analysis from the German breast cancer group suggests that there is safety, and the recent Alliance study, a phase 2 study, suggested that this is possible. Keep in mind, however, that in order to do that, most of the patients needed, and they will need, a preoperative MRI, and adherence to systemic treatment and boost radiotherapy are of imperative importance. Is oncoplastic surgery always necessary? So, in general, the short version is no. You do not necessarily need to resort to an oncoplastic technique, but if you need to avoid a mastectomy, then you will probably need to do it. But the thing that I want to stress out is that thinking oncoplastic, thinking about the outcomes that you expect and wish to achieve, does not mean that you need to commit yourself from the very get-go to a specific oncoplastic technique. So you just need to define the following that we went through: the minimum necessary operation, the wishes and expectations from the patient sides. You need to inform and provide all alternatives. You need to have a backup plan in case of involved margins, so you need to be certain that you could potentially offer a re-excision without landing to a mastectomy. And you should allow for a decision-making from the patient's perspective that is sometimes, it may be beyond our own comfort zone. And as a rule of thumb, I mean, we think in norms. If you've got a large and ptotic breast, that's the easy part. A large and ptotic breast with skin excess can always be lifted, reduced, and dealt with in an easier manner. So a breast mount is easier to reshape and recreate because it is a fusion of these 3 principles. Vertical and wise patterns are, in standard fashion or with glandular rotation, are my personal working horses. I'm not suggesting that these are the only things that you need to do, but I feel that they work best because you can treat the skin envelope in a more efficient manner, and you do not burn the bridges if you need to go to a mastectomy. And don't forget that in these cases, if you need to uphold the projection of the breast, you need to reduce the base, because this is conceptually in the design of these types of operations. And that way, you can start from something like that and come to something like that. Or you could start with something like that. That was a little bit challenging because it was near the nipple areola concept, and take a big specimen, a quadrantectomy, a central quadrantectomy, and land with that. Or even in the most challenging cases, a pleomorphic lobular cancer that is very, very big, that lands here. What about the others? This is the big conundrum. So the smaller and non-ptotic breast, you cannot reduce a small breast, you cannot lift a breast without ptosis. So the shortage of techniques over there, at the same time you have a good skin envelope, this is something that triggers the mastectomy and implant-based reconstruction, you usually go that way, and these patients do not get the chance to discuss something else. The problem is that we do not know formally who needs the mastectomy. So what we did in a multi-center cohort, a prospective cohort of perforator flap reconstructions, is that one of the things that we tried to do with the 603 patients was to take prospectively the surgical assessment. Is this a need for mastectomy, or are we offering the flap to have superior cosmesis, for example? And we constructed a nomogram that landed in a mastectomy population that would be a little bit more rigid. So we went there, and you see that we are talking about patients that have smaller breasts, something more than a quadrantectomy, about 27% resection ratio as a median, and mostly medial and central tumors. And the nomogram looked something like that. So more or less, the calculated resection ratio plays a role, but you see that the breast volume and the quadrants are also independent prognostic factors for that. So given these, we went back to the previous algorithms that I showed you, and no algorithm could retain prognostic significance in that, highlighting a little bit the fact that these are kind of common sense, but we still need data behind that. And I will just scroll through several cases. So here you've got a breast that needs something more than a quadrantectomy. It is not ptotic. It is empty on the upper pole. So the options of lifting or making it smaller are not really viable. And we went there. A small breast with a DCIS that needed a quadrantectomy, lower outer quadrant. We solved that with a perforator flap, and these are the results at 2 and 3 years. A fusion of techniques, a woman with a multifocal lesion and a node. She got chemotherapy. She had a footprint due to the microcalcifications, and then we went back, and this is how she looks at 2 years post-surgery. The case of the upper inner quadrant, I know that it is a very challenging thing, how to reach, how to feel, and how to shape that. I usually try to go with a lateral flap. I prefer the LTAP in these cases, if I do not need to resort to a TDAP from the very beginning. I try to make a long but not broad flap so that I get a reach, an adequate pivot point in order to fold and maintain projection. I mobilize the upper outer quadrant from the fascia but not the cranial ligaments, and then I tunnel the flap that wants to go in the medial quadrant under the quadrant. And this is a case that in the end looked like that. Or this patient following adjuvant chemotherapy and not complete radiologic response, where you still needed a 20% from the medial part, and you see how that settles down. You see how well the flap sits in the CT imaging from the design. And I always try to overfill, because what you see is that the breast is swollen in the beginning, but there is a loss of volume following radiotherapy afterwards. And this is what gives her the long-term symmetry. The case of the lower inner quadrant, find the perforators beforehand, because this is where you need your medial perforators that are, for some, easier to make. I feel that they are more challenging because they are broader but shorter vessels, so you cannot deal with rotating them a lot. And you just need to find it from the very beginning. You see it, you did an MRI, it's already available, you know where they are, and this is how it looks like afterwards. Or this case, this lady with a small breast that had a 3-centimeter lesion from her 6 o'clock that landed with that, or something similar to that. Sometimes thinking outside the box means that you need to converge techniques. So we had this lady that had an 9-centimeter lobular cancer, and she's after massive fasting. So you see that she's very ptotic, she's very empty, she's got skin redundancy, but you do not have parenchyma to address the situation just by giving her a reduction and a lift. So this is how the breast is going to look like. So we need to assess the supply sources for the remaining parenchyma, and this is what you do with the ultrasound, and you have to map it carefully. And your key question is, do I have enough volume to reshape the breast mount as it is? And you need more volume, so you need to recruit outside the breast. So if you're going for a wise pattern, because the nipple areola complex has to disappear since it has been invaded by cancer, you start finding the lateral vessels. The ultrasound is very beneficial, and you see in this way that you have a flap that can be oriented this way, or this way, or this way. So you make the decision looking at the patient, and you just modify the horizontal limb. This is how the lateral thoracic artery will look like with the ultrasound. This is the optimal flap with a broad base that can be rotated easily inside, and this is how you design it. So now it starts making sense how we're going to do that, right? So we just start deepithelialization. We perform tumor resection and then degloving of the gland. We go laterally in order to be able to go behind the gland and respect the blood supply that is laterally to that. So following this excision, you still have the circulation that you need for the remaining breast parenchyma, and then you can intraoperatively define where the perforator is and make sure that you don't have a problem with that. And moving to the mobilization of the perforator, this is how it's going to look like schematically. In truth, you perform some segmentation based on the circulation that you have, and you land in this. And this is how she looked just a week after surgery. Okay, so the key points, just to go through that again, is that due to the data that Kostas will be talking about, we have a good motivation to discuss breast conservation in cases that are beyond tradition or beyond our comfort zone. We need to redefine how we think about the approach and the standardization of the surgical assessment in order to obtain that in a reproducible and stable manner. We need to start thinking oncoplastic, but outside the techniques that we are familiar with. So by doing that, you expand and you tailor the technique to what you need. And this is what we need to do as breast surgical oncologists. And in cases of patients that fit the criteria, for example, for multiple resections, this can be considered given the limitation of the available data. Thank you very much.
Thank you, Andreas. It was an excellent presentation. I think we have lots of questions for later on, but let's carry on with Konstantinos Zacharyudakis, who's a friend, and he's a consultant oncoplastic breast surgeon in the United Kingdom, and he will talk about the safety, I guess, of breast conservation and whether that is better than mastectomy.
Yes, thank you for the invitation. It's always good to be back home. I'll try to keep it short, keep in time so we can have a discussion afterwards. I have no conflict of interest to declare. So breast cancer surgery has improved substantially over the past decades. Up to the 1980s, modified radical mastectomy was the standard treatment for most patients, regardless of the stage of the disease. Since the 80s, several randomized controlled trials have shown that breast-conserving surgery followed by radiotherapy is as effective as mastectomy for the treatment of breast tumors up to 5 centimeters. So in 2002, Fisser and Veronese published the long-term outcomes of the NSABP B6 trial and the Milan trial, respectively comparing breast-conserving surgery and mastectomy. Both studies showed that women with early breast cancer who were treated with breast-conserving surgery and postoperative radiotherapy to the ipsilateral breast had higher rates of local recurrence but similar long-term survival when compared with those undergoing modified radical mastectomy. So in 2011, the Early Breast Cancer Trialists Collaborative Group published an overview assessing the multiple randomized controlled trials, concluding non-inferior overall survival with breast-conserving surgery. So the overview identified many weaknesses, such as lack of detail regarding involved excision margins with breast-conserving surgery. Most of the trials required negative surgical margins after breast-conserving surgery for invasive cancer, although not for DCIS. Furthermore, as histopathological techniques have become more sensitive since women entered these trials, some would probably have been positive with modern criteria. The quality of breast cancer surgery has also substantially... Sorry about that. So the quality of breast cancer surgery has also substantially improved. So in the ORTC trial, 48% of patients had positive margins. So microscopically positive margins compared to the EORTC boost versus no boost trial where only 5% of patients had positive margins. Nowadays, 10-year rates of local recurrence of less than 5%, I don't know why it's doing this, sorry, is not uncommon. So the last decade, we have witnessed significant improvement in breast cancer-specific survival and overall survival. Since the 1990s, the 5-year risk of death from breast cancer in the UK has decreased from 14.4% to 4.9% overall, with reduction seen in nearly all groups. randomized control trials form the basis of surgical decision-making for breast cancer patients worldwide. However, within the context of modern treatments, should we consider their outcomes as anachronistic? So, recently, large data sets from cancer registries around the world with over 1.3 million women are at variance with the seminal papers, suggesting that overall survival is superior and not non-inferior with breast-conserving surgery. I'll summarize the key findings of these cohort studies and their implications on surgical decision-making while acknowledging the context of real-world data sets as opposed to randomized control trials. So this study analyzed data extracted from the SEER database. The aim of the study was to compare breast cancer-specific survival rates of patients undergoing breast-conserving surgery, mastectomy alone, or mastectomy with radiation using a cohort of patients treated between 1998 and 2008. Early-stage breast cancer was defined as having a tumor size of 4 centimeters or smaller with 3 or less positive nodes. So a total of 132,000 patients were included in the analysis. Around 70% of patients had breast-conserving surgery, whereas 26% had mastectomy alone, 3.4% had mastectomy with radiation. As expected, a higher percentage of patients who underwent mastectomy alone or mastectomy with radiotherapy had larger tumors or positive lymph nodes compared to the patients who received breast-conserving surgery. So the 10-year breast cancer-specific survival rates for patients treated with breast-conserving surgery, mastectomy alone, or mastectomy with radiation were 94%, 90%, and 83% respectively. These differences were not surprising and can be explained by the presence of more advanced T and N stage in the mastectomy and mastectomy with radiotherapy cohorts. However, when we stratify patients by tumor size and lymph node status, these differences persist. So on the left, we have patients stratified by treatment method and tumor size, under 2 centimeters versus over 2 centimeters. And this demonstrated higher survival for patients who received breast-conserving surgery compared with their tumor size matched cohorts treated with mastectomy alone or mastectomy with radiation. So on the right side, we have patients stratified by treatment method and lymph node status, lymph node negative versus lymph node positive, again demonstrating higher survival for patients who received breast-conserving surgery compared with their lymph node matched cohorts treated with mastectomy alone or mastectomy with radiation. So even when controlling for lymph node status, when patients were stratified based on tumor size of under 2 centimeters or between 2 to 4 centimeters, those who received breast-conserving therapy continue to exhibit improved survival when compared with patients treated with mastectomy alone or mastectomy with radiation. So on the left, we have tumors that are under 2 centimeters, and on the right, between 2 to 4. And we see on the top are the node-negative patients, on the bottom, the node-positive. And you see that breast-conserving surgery has improved survival for under 2 node-negative and for under 2 centimeters node positive, and the same for over 2 centimeter tumors, node negative and node positive. So in all subgroups, breast-conserving surgery was superior to mastectomy or mastectomy with radiotherapy. So in multivariate analysis of breast cancer-specific survival, women undergoing mastectomy alone had a higher hazard of death, which was 1.31, than those undergoing a breast-conserving surgery. Women undergoing mastectomy with radiation also had a higher hazard of death, hazard ratio 1.47, than those undergoing breast-conserving treatment. So this study from the US analyzed data from all women diagnosed in the state of California with stage 1 or stage 2 breast cancer between 1990 and 2004. Analysis was stratified by age group, under 50, over 50, and tumor hormone receptor status, which were not included in the previous analysis. Overall survival and disease-specific survival were compared between the breast-conserving surgery group and the mastectomy groups, adjusting for tumor grade, tumor size, age, proportion of positive nodes, race, and socioeconomic status. Median follow-up, 110 months. So the unanticipated finding for the authors of this study was that patients treated with mastectomy had a significant lower overall survival and breast cancer-specific survival than women who underwent breast-conserving treatment, even after adjusting for tumor grade, proportion of positive node, race, socioeconomic status, tumor size, age at diagnosis, and year of diagnosis. Long-term breast cancer-specific survival after breast-conserving therapy was either equivalent or superior to mastectomy in all age groups and hormone receptor tumor types, with almost 10-year median follow-up. The strongest association with the outcome was observed in those older than the age of 50 with hormone receptor positive tumors, who had a 14% lower breast cancer mortality and a 19% lower overall mortality with breast-conserving therapy than with mastectomy. The least benefit was demonstrated in women under 50 with hormone receptor positive tumors, where the hazard ratio was 0.94. So this cohort studies from Sweden. It included all women diagnosed as having primary invasive T1, T2, N0 to N2 breast cancer and undergoing breast surgery between 2008 and 2017. The aim of this study was to determine whether the reported survival benefit of breast conservation documented in recent cohort studies is eliminated by adjustment for two pivotal confounders, comorbidity and socioeconomic status. So why are these two factors important? Individuals with a lower socioeconomic status present with more advanced disease, have a lower adherence to mammography screening, are less likely to receive chemotherapy, and have inferior survival rates in addition. And in addition, lifestyle factors, increase in cancer risk, impacting survival, such as obesity, smoking, these are more common in socioeconomically deprived groups, in addition to comorbidities that negatively affect completion rates of systemic therapy. So furthermore, comorbidity is directly associated with overall survival, but can also be associated with breast cancer-specific survival, modulating adjuvant treatments. For example, breast-conserving surgery is less common in women with a lower socioeconomic status, which in turn is associated with multimorbidity, a more advanced stage at presentation, lower rates of adjuvant chemotherapy, worse survival. And furthermore, comorbidity is associated with a choice of systemic and local regional treatment, as long as also with survival. So when stratifying by prognostic group, the associations varied substantially. Mastectomy without radiotherapy was associated with an increased overall and breast cancer-specific mortality rates compared with breast-conserving surgery with radiotherapy, regardless of the prognostic group, with the exception of T1 and 1, where no association was found. Mastectomy with radiotherapy was associated with an increased overall mortality rate in T1 and 0, T1 and 1, and T2 and not, but not for T1 and 2. So in conclusion, this report supports the recommended use of breast-conserving surgery with radiotherapy in both node-negative and node-positive breast cancer. Neither socioeconomic background nor comorbidity diminished the survival benefits. This report casts additional doubt on the practice to offer mastectomy to patients who are suitable candidates for breast-conserving surgery. So a group of researchers from Denmark carried out a systematic review and meta-analysis of data from all these cohort studies and published the results in 2022. Studies were eligible for inclusion if a proportion of the sample had been treated with breast-conserving surgery, were compared with patients treated with mastectomy, and provided data on overall survival and breast cancer-specific survival. Studies had to be population-based, observational studies, and randomized control trials, and hospital-level single or multicentric studies were excluded. A total of 30 studies were included in the review that reported survival data for patients treated between 1990 and 2014. So 13 independent studies with a total of more than 1,300,000 breast cancer patients provided data on overall survival with a median follow-up of 75 months. The patients who had received breast-conserving surgery had better overall survival than patients who had been treated with mastectomy, with a difference corresponding to a hazard ratio of 1.34. Larger differences were found for older patient samples, or more than 50 years, European samples, and samples in high-quality studies. When using meta-regression to explore the moderating influence of lymph node status, age group, region, and number of relevant prognostic factors adjusted for in the analysis, only time to follow-up and study quality emerged as statistically significant moderators, with shorter time to follow-up and high study quality being associated with greater differences in both overall survival in favor of breast-conserving surgery. So when examining the role of adjusting for individual prognostic variables such as tumor type, hormone receptor status, HER2 status, endocrine therapy, and comorbidity, no results reached statistical significance. In subgroup analysis, the differences in overall survival in favor of breast-conserving surgery was larger when compared to mastectomy without radiotherapy than when compared with mastectomy with radiotherapy. So examining now breast cancer-specific survival, 14 studies with a total of close to 500,000 breast cancer patients provided data on breast cancer-specific survival across a median follow-up of up to 78 months. The patients who had received breast-conserving surgery had better breast cancer-specific survival than patients who had been treated with mastectomy, with a difference corresponding to a hazard ratio of 1.38. Larger differences were found for older patients, older than 50, European samples and samples in high-quality studies, whereas the difference did not appear to be associated with lymph node status. So when examining the role of adjusting for the individual prognostic covariates, which exhibited sufficient variation, tumor type, hormone receptor status, HER2 status, endocrine therapy, and comorbidity, no association reached statistical significance. So as seen for overall survival, the difference in breast cancer-specific survival in favor of breast-conserving surgery were somewhat larger when compared to mastectomy without radiotherapy than when compared to mastectomy with radiotherapy. Hazard ratios were 1.43 versus 1.36. There were 3 SEER studies focused on triple-negative breast cancer alone. All 3 studies showed a better outcome after breast-conserving surgery, with reported differences in overall survival 9%, 5%, and 8% respectively. One further study reported on metaplastic breast cancer and described a remarkable 22% better 5-year overall survival with breast-conserving surgery. So the results of the systematic review and meta-analysis of recently published population-based observational cohort studies of more than 1.3 million breast cancer patients provide compelling documentation that early breast cancer patients treated with breast-conserving surgery and radiotherapy have on average a 34% better overall survival and 38% better breast cancer-specific survival than patients treated with mastectomy. The results in favor of breast-conserving surgery hold true regardless of whether mastectomy was combined with radiotherapy or not, and for all analyzed subgroups. Lymph node negative patients, lymph node positive patients, younger than 50, older than 50, triple negative patients, and patients treated in Europe as well as in North America. So there are currently no agreed upon explanations for the observed differences in survival between breast-conserving surgery and mastectomy in breast cancer, and for why the recent observational studies report a more favorable outcome after breast-conserving surgery in contrast to the earlier randomized control trials. It's important to note that it cannot be ruled out that the patients who received breast-conserving surgery differ from the patients that had a mastectomy. Due to the nature of observational data, we do not know the reason for the actual choice made in each of the individual clinical situations. However, when interpreting the results, it's important to note that all the included studies had adjusted for a number of prognostic and treatment variables. So although the number of covariates varied considerably between studies, almost all studies had adjusted for age, tumor stage, tumor grade, nodal stage, and several had adjusted for hormone receptor status, comorbidity, radiotherapy, and chemotherapy. Still, relatively few had adjusted for HER2 status and endocrine therapy, and almost none for lymphovascular invasion and focality. No studies had adjusted for anti-HER2 treatment. So when examining the possible role of adjustment for a number of individual prognostic factors, including comorbidity, tumor type, hormone receptor status, HER2 status, or endocrine therapy, none of the associations reached statistical significance. Furthermore, when meta-regression was used to explore whether the difference found between breast-conserving surgery and mastectomy was influenced by the number of prognostic covariates adjusted for in the analysis, this did not appear to be the case for neither overall survival or breast cancer-specific survival. Taken together, the data suggests that the differences observed in survival are not sufficiently explained by differences in prognostic characteristics. So several explanations have been proposed for the observed differences in breast cancer specific survival and overall survival between breast conserving surgery and mastectomy, with the role of adjuvant radiotherapy in breast conserving surgery postulated to be important. Radiotherapy to the residual breast destroys small foci of cancer cells left behind after the breast conserving procedure. During this procedure, it mobilizes host immune mechanisms, leading to the inactivation and destruction of remaining tumor cells and micrometastases to the body. Furthermore, breast-conserving surgery patients receiving adjuvant breast irradiation, tangential fields will include the lower axilla, and this may play a role in the prevention of locoregional relapse in cases of false negative sentinel nodes. So moreover, despite evidence showing that regional nodal radiotherapy improves disease-free survival and distant metastasis-free survival in N1 patients, this is not the standard of care with mastectomy, yet will be almost universal for breast-conserving surgery. Finally, the higher incidence of complications following mastectomy can reduce immune capability, affecting the ability to combat distant breast cancer cells. Oops. And so, to conclude, patient choice and shared decision are the cornerstone around which patient care is delivered. However, true patient choice is predicated on equivalence of outcomes between the treatment choices. There is a large body of evidence indicating that in patients treated with current day standards of care, breast-conserving surgery may have a survival advantage over mastectomy with long-term follow-up. Hence, it's important that patients are informed of the evidence relating to breast cancer-specific survival and probably overall survival when choosing mastectomy if breast-conserving surgery is feasible. Thank you.
Thank you very much. Very comprehensive speech. I believe we have a lot of questions, but first I would like to listen to comments from our three commentators. Maybe some of the answers will be of the questions will be answered. First, I would like Mr. Vasilis Karidakis. He is a consultant breast surgeon at Guy's and St. Thomas in London.
How can I speak from here?
Είναι ανοιχτό μικρόφωνο.
Okay. Yeah. So we are lucky that you have two friends here and for two excellent presentations, Andreas and Kostas. I believe that the future of surgery, of breast surgery, is to eliminate our operations for small cancer, for good stage cancer, and also after neoadjuvant chemotherapy with good or complete pathological response. Andreas has a very big experience and big number of patients in his center, and I believe that we can achieve the good results from the beginning. And we have, in my opinion, priorities to achieve a good oncological outcome first. Second is to share the decision with the patient and discuss about the cosmetic results. Of course, the satisfaction of patient at the end is very important, but the most important is to have good oncological outcomes, and this starts from our surgery. Now we can remove 50% of the breast volume with good cosmetic results. I would like to ask Andreas, how can be sure that we avoid the re-excision? Because in the past we used frozen section during the operation. Now in UK we abandoned frozen section. Of course, we extract the specimen, we do some shaving at the margins, and but it is very important to reduce the rate of re-excisions in a second operation. Our techniques improving. We do all these mammoplasties. In my opinion, the most difficult area is the upper inner quadrant of the breast, and there it is a problem to use this easy for me local flaps like LICAP, like ICAP, all this. Now breast surgeon can do that without plastic surgeons. But we must be sure that we have completely removed the tumor, which is very important because it's difficult to go back and remove more tissue. Also, after all these high-level trials and series you presented, I believe that, of course, we can offer to the patient very good survival, better survival with breast-conserving surgeries. And at the end, we have to do the treatment tailored to our patient and do more for patient and less to the patient. Thank you.
I would like a comment also from Dr. Metaxas. He's director at the NHS, Greek NHS.
Okay, I would like to thank both speakers for their excellent presentations, state of the art. I am very impressed by the percentages of breast conservation in Andreas's unit, and I would like to know how he handled the patient opinion on that, which because there is in the diagram there was a point where suddenly everything went breast conservation. There's a very strong message during the last couple of years that is not just choosing between breast conservation or mastectomy. We now have to justify why we choose a mastectomy and document. And in Greece, this is surgeon dependent because most of the practice until at least 2017 or 2018, I think the mastectomy rate was around 60%, which is very high. We're not sure what the percentage is now because there's no database, there's no national database, and I think there should be a registry for that. And a small question for address, is there any prospective or retrospective data on breast conservation plus radiotherapy on BRCA patients, on gene carriers? I mean, in regards with mortality and recurrence and everything. Thank you very much.
And to complete the comments from Dr. Stafila, who's Chief of Surgery at Mitera Hospital.
Yes, thank you very much for your lectures. First of all, for Mr. Zacharidakis, I think you definitely convinced us that breast surgery is better than mastectomy. However, I don't understand the reason why. I'm not sure it's very clear why this is happening. So we have to still search into that. And for Andreas' talk, it was really impressive what we can do nowadays with breast conservation. However, I think we still need a very good planning before we start operating, before we start doing flaps. We need a very good radiologist to assist us with our mapping so that we make sure that we can do a wide excision and we don't need to go back and reoperate because that should always be a problem when you do flaps and like very advanced techniques inside the breast. And my question is about radiotherapy. How easy is it to irradiate a reconstructed breast with all these flaps inside? I think we do have radiotherapists here to answer these questions. Thank you.
Thank you very much for the comments. So while you were talking, I was building up questions, and you were actually answering my questions because there was a big scrutinizing about how come having mastectomy and radiotherapy be worse than having breast conserving surgery and radiotherapy. And I thought, okay, maybe it's a subtype. They didn't check for triple negatives, and etc. And then you answered that. And maybe it was that, and you answered that. So what's the answer? How come they're better? Because if I remember in your curves, breast conserving surgery with a knee, 0 tumors, are knee 1, 2 are equal as mastectomy with knee 0, which is quite a difference. So, do you have any answers?
So, yeah, I showed you some explanation, some attempts to interpret this data. It doesn't mean that we know why this is happening. So it might actually be that the patients having mastectomy or mastectomy with radiotherapy do have some differences that were not included in all the confounding factors that we were checking. So why it's happening, we don't know. One explanation regarding mastectomy with radiotherapy has to do with the fact that when you do breast-conserving surgery and give radiotherapy afterwards, it's likely, why do we give radiotherapy? There's cancer left behind, and that's what radiotherapy treats. And there's an effect that when you treat with radiotherapy the cancer cells that are left behind, it triggers the immune system, an immune response. And we've seen that in other types of cancer, metastatic cancer where they have radiotherapy in the primary tumor and you see regression in metastases. This hasn't been really proven for breast. This is, a hypothesis, but this is a possible explanation between why in breast-conserving surgery, where you irradiate the remaining breast, you trigger the immune system, and this has an immune response against possible micrometastases that will affect breast cancer-specific survival or overall survival. Trying to find explanations is really difficult, and what I would like to communicate, and I asked to present, I thought this is an important message to communicate, is that we won't be able to do any more randomized control trials. They tried with the Miami trial, it's not happening. It's unethical to do a new randomized control trial, and randomized patients will do mastectomies and wide local excisions. What they were doing in the randomized control trials differs so much compared to what we do now on every aspect, radiology, endocrine therapy, sentinel node biopsy, how they were choosing to give chemotherapy. They were not giving taxanes at the time. There was no anti-HER2 treatment. Only node-positive patients received chemotherapy. Nowadays, we have molecular profile. It's completely different, everything. Surgery is different. You have a randomized control trial with 50% of patients having positive margins. Yeah. These data, they are randomized control trials from 50 years ago. That's when they started recruiting patients. So we won't be able to do any more randomized control trials. I'm not saying that, the numbers that I showed you, that's the actual difference that we would see in a randomized control trial if we did it today, but we cannot ignore it. And when you have a conversation with a patient, some patients tell me, shouldn't we remove the whole breast? Wouldn't that be safer? So, and what I used to tell them before I became aware, like a couple of years ago, of all these cohort studies, I was telling them, survival is equal, there's a higher rate of local recurrence. And maybe this should change, and you should inform them that, look, there's a lot of data that has been accumulated over the last years, so maybe removing less breast probably will improve your survival.
I think this is a good message.
That's a message.
So, do you have any questions? Okay, of course we have questions. Before we answer, wait, just a second. Because Mr. Maragoudakis obviously wants to answer the question about the radiotherapy. I think that's important to cover that before we move on.
Well, thank you, you surgeons, that you respect radiotherapy that much. And I would like to give an explanation. Imagine the surgery is a circle. And imagine a second circle that is wider outside the first circle. This is radiation. So we include more tissue than what you surgeons can do. You take out what you see, but what is not seen is a matter of radiation. On the other hand, why, when we radiate patients with mastectomy and they don't have better results? Because when we radiate after mastectomy, we have very serious factors, such as 4 lymph nodes infected, and this is very bad prognostic factor. That's why after surgery, after mastectomy, we don't have that good result. What we haven't tried is to irradiate the ladies that they have good prognostic results, such as only 1 or no lymph nodes, but because radiotherapy has side effects, that's why the reason we don't recommend that.
Και Mr. Askoxilakis. It's difficult to say your name in English, actually. It's easier in Greek.
It's easier for me to speak in Greek. In any case, one question for Andreas. In the case you have residual disease after the oncoplastic surgery, how do you remove this? Sometimes it's not very easy. Transposition of the flaps, changing the position, cavity, not very easy to excise. And I want an answer. You prefer mastectomy or you? Okay. Would you like?
Andreas. Yeah.
Thanks, Kostas, because you made my lecture more plausible. So, with regards to all the questions that we got, when we are discussing surgical planning, let me not turn my back to people. So, when we are discussing surgical planning, what the OncoPro Value Protocol is all about is that you need to have a plan A on what to excise from the very get-go, and this is where you need the radiologist, and this is where the entire multidisciplinary team need to be part of that. But it is obligatory to have a plan B and a plan C, meaning that you address a target area that you intend to remove. What we do is that we have a coefficient of 0.5 if you have a lobular cancer or a multifocal DCIS. So that means that you adjust the volume that you will remove for that. That's the one thing. The other thing is that you need to assess the volume and discuss what are the options in cases of re-excision. In our series, the OncoPro, we are accumulating some more results. We are approximately to 1,300 patients now, but the conversion rate to mastectomy is 1.3%. Interestingly, it has to do with radiologically local disease or micropapillary variants that are completely invisible for radiologists. So you convert to mastectomy if my strongest reason for converting to a mastectomy following positive margins is if I get histology that is not detectable during follow-up. Okay, so you need to have a plan A and a plan B in order to do that. Re-excision following flap reconstruction is much easier than re-excision following a therapeutic mammoplasty. And the reason for that is that if you have performed a lateral flap for the lateral breast, your usual suspects are the margins that are towards the nipple areola complex. This can be very easily addressed without opening the big incision. You just do a periareolar, you find the cut area, you go there. At the same time, we have a very standardized protocol when we are doing oncoplastic surgery, both volume replacement and volume displacement, about the number of clips that you will put on each side of the resection cavity. So there is no randomness there. You have to be prepared. So it's not something that you go back to work and start doing it Monday morning without adjusting for all these things. You need to be well prepared. You need to be structured, and I tend to be less democratic when it comes to these things with a unit. So all the surgeons that work this way have been trained this way. Okay. The question with regards to radiotherapy, there is an interesting systematic review that was a little bit poor, I think, because the data is not really there, published on Cancer Treatment Reviews, discussing on whether there is a necessity, whenever you do a flap, to go for boost radiotherapy. The local and national practice in Sweden does not support that, and our current data actually suggests that it is the age that you need to adjust for and not any other factors. By the way, in Sweden, we do not accept focally involved margins, so we're not like the Dutch that will just give boost radiotherapy and go for that. We will re-excise if this is the case. The other thing that we need to discuss is how patients work like. So if I had the curves of the last 5 years, you would see that the increase was successive. And one thing that makes things different is that we are currently increasing the breast conserving rates of other regions in Sweden because we get a lot of second opinions. So it is the word of mouth on that. At the same time, the Swedish registry is rigid. You cannot trick it. So we have a real-time follow-up of patients with regards to their oncologic outcomes. We are aware of the fact that we do not have mature data to discuss 10-year survival outcomes, for example. But until now, what we have is local recurrence, which I think is kind of a more successful surrogate in this case, is that we have similar local recurrence rates with any other type of surgery when you adjust by stage. So that is quite comforting per se. This is something that corroborates on a nice cohort study published by Dick Rainsbury, 500 patients, 10 years follow-up. I got it in the EJSO a couple of years ago, or 3 years ago, I think, that showed the exact same result. And this is the reason that I personally feel that we need to individualize patient assessment, we need to tailor our approach towards that direction, and we need to gradually start to abandon the term extreme oncoplasty, because this has a negative nuance. This is nothing extreme. If you can remove what you see, you remove it, and you produce a breast that the patient will live with. Let's not forget that the patients still have a diagnosis. They have a solid tumor that has probably among the best survival rates in surgical and clinical oncology. So we have to start reframing how we think, and we have to start discussing that the patient, this is not a pancreatic adenocarcinoma, that they will die regardless of what you did. They will not die of the disease, but they will have to live with what you did to them. And this is a very important message, and this is where you need to take all these things into account. Finally, the shared decision-making. The shared decision-making is a little bit of a vague concept, but if you look into the science of it, it is very well standardized. Clinical psychologists from Italy and from Milan particularly, and from the UK have pioneered that. So what we use is a very standardized approach in which the patient will receive information which is the obligatory from the Swedish Cancer Institute, but they will receive oral and written information that is tailored to their specific prognosis and options. So this, what you see behind these pictures, because I did not show you any particular numbers, since that was not my topic, is the result of very well standardized work. So we changed how we deal with things a lot. We changed it because we have the luxury, we learned that we need to communicate. So the radiation therapist needs to be part of the discussion. Can you do that for me if I do that to the patient? The patient needs to be aware of what the complication risks are, how things work like in this direction. And I think that until now the data is quite safe and compelling to move forward with that. The only thing that we will not be doing with the OncoProValue trial, I reapplied for that because I had gotten ethical approval. Given the observational data that we were using to generate reference values for a randomized control trial, the Swedish ethical authority rejected that on the basis that it would be unethical to do a randomized control trial to test the concept.
Thank you very much, Andreas. I think Corina wants to give a question, and if there are not...
Thank you very much for these very, very high-level presentations. I would like to ask Dr. Zacharidakis. We tried to explain why a mastectomy is now proved to be inferior than breast conservation therapy with breast conservation with radiotherapy. In former years, we thought they were equal, but it has to do also with what kind of a mastectomy you do, because former studies, the mastectomies, they removed more skin. So I wanted to ask you how many skin-sparing or neck-sparing mastectomies were included in, in these trials, because if they were more generous in leaving back tissue in former years as these procedures started, so it can be that this is the reason also.
Okay. So to answer your first question, the answer is that we don't know. These are cohort studies with like 130,000 patients or 50,000 patients. They do not mention, whether they had reconstruction. But your point is very valid. It's one of the proposed explanations. Are all mastectomies equal? So if you do so no. So this was one of the explanations. These are, hypotheses. So one explanation is that maybe some people do a mastectomy and leave breast behind. That patient won't have any radiotherapy, whereas, breast conserving surgery, they will definitely have radiotherapy. So this is a very valid point, and not only for skin-sparing mastectomy, not even more simple mastectomies, one might argue, are not the same. these are hypotheses that have been made to try to explain the data. I don't necessarily agree with all of them. I had to present it to you. That's, all these papers, that's how they, in the discussion, segment, that's how they try to explain these differences. But, yeah, the answer is we don't know.
Yeah, but there are more than few confounding factors that they haven't included.
This is important, to clarify, because there was some mention about lymph node involvement and radiotherapy. They were comparing like to like. So they were adjusting for, it's not like they were comparing bigger tumors that had mastectomy with smaller tumors that had breast conserving. The analysis had adjusted for all these factors: lymph node involvement, size, grade. The question is, are there any other factors that will improve overall survival or make it worse for patients having mastectomy that were not included? But all these factors, like lymph node involvement, it was included in the analysis. They adjusted.
But these are the obvious factors. There are some other factors that are not obvious. For
The
example, the
known-
status of the patient. You get 70-year-old patients. They're not equally healthy. So this might have been one of the factors, but we'll never know. We'll never know. I guess.
This is one of the drawbacks. These are, cohort studies. So this is one of the main drawbacks of, of that type of.
That's right.
Competes
for the microphone.
With regards to the study type, and just in my academic and editorial role, what we need to be very clear about is that no matter what you do, you cannot exert causative effects from non-randomized material. A cohort study is a cohort study. Moreover, we need to make a very significant differentiation here. These are not formally cohort studies. These are registry-based studies, which means that the patients cannot be formally, during analysis, treated as patients, but they are treated as data entries in a registry, which means that the studies are as good as the registry is, and they cannot be better than that. They adjust for non-confounders. Non-randomized material has a non-confounders as well. What we decided to do in Sweden in order to find a way to medico-legally inform the patients in a manner that is relevant but reasonable in the context of these limitations, and we had the patient association with us that agreed on this, is that we can now tell patients that on the basis of all these findings, we can say that breast conserving surgery followed by radiotherapy is at least as good as mastectomy with or without radiotherapy.
I think that's the message that we need to give to everybody. So I think everybody needs to go for a coffee now. So we're gonna thank everybody for the contribution, and we're gonna see you back in 15 minutes.